All right, so today we're doing a little thing that's going to be a little different than all of our other echoes we've done for this group.
Or ever.
Clinical pearls, more of a discussion. So that's what's today. There's free CME, Heather.
Oh my gosh.
All you got to do is just ask for it and fill out the little thing.
This is funny. I don't know why.
I just keep going. Next slide.
Turn your videos on if you don't mind. These are recorded, as you all know. You just got the alert, and I don't remember. Oh, attendance. If you have other people in the room that are not, named, please snap or chat in. Please chat in.
Is our audio okay, Candy? Okay, perfect.
Okay, upcoming. So we're taking a couple weeks off because of the holiday. So we will do perioperative management with buprenorphine, and what do you do if someone's on buprenorphine, all of that. And then after that, community collaboration. And then we're doing what is a lapse versus relapse, and how do you talk to a patient? Tomorrow on the Wednesday Echo, sex trafficking and patients who are in recovery and that whole thing. And then how do we talk about pain and CBD? I can't every single time.
CBT.
Yes.
So that's Murray McAllister coming for us. So he's always a great speaker.
If you need help or assistance with absolutely anything, please let us know. There's our emails, our cell phone numbers. Kate Aaron's our nurse, and she's on as well. She can definitely help troubleshoot whatever as well.
All right, remember there is the resource center. You can go to this website and find just about anything you'd ever want to find. All of our different forms, everything.
They're gradually getting there.
They're gradually getting there, so please explore that.
Any videos or whatever of any echoes in all of the above. So cases, we really need cases. So please, if anybody has any type of a case, whether it's opioid use disorder, addiction of any kind, or pain meds, all of that, you go to that website or the MAFP website or the announcement email, click on the Find an Echo, click on More under this Echo, the Stratus Health MAFP Echo, and then fill out and do the form. You can actually online submit it, and we did way simplify that form. So
if you need help, just ask Katie. Just Katie Stenko.
Katie's not on this one.
Oh, that's right.
Ask
Never mind.
Otherwise, just free, case presentation. Today we have 4 made-up cases.
Yeah. Remember the podcast, weekly addiction topics. I don't even know what came out.
Today is opioids as weapons.
Weaponized opioids. And you may remember that from Russia when they pumped in carfentanil.
Don't give it away.
Long story.
All right. So today's objectives, we'll just get there. So like Kurt mentioned, we're going to kind of have a conversation. If you all want to pipe in, please do chat us in if you want to add to this. I'm going to move this out of the way. And then what we're going to do is we're going to kind of put up a case or a patient. We kind of made these up just to kind of proof points. And this is more like, what do you do on the daily? We can teach you all you want to know, but cases come up and patients come up. That's why we like case presentations and how we talk about it, how we think about it. So there's not really a test, but it'd be funny if there was. All right. How about I give this one to you?
That's right.
Okay, so you have a patient, they start treatment. So they started with you in your MAT clinic. They relapse, whether it's days, they relapse in months, they relapse in years. Every time they come in, maybe their urine is appropriate, maybe there's meth or other things. What do? Would you kick somebody out of your program, Kurt?
Yeah, I think that speaking for myself, I think that a lot of things have changed in the 5 or 6 or 7 years that we've been doing this. And just today, I had a patient who could no longer go to a clinic not too far from here that because they'd missed a bunch of appointments, and the person has a very clear severe opioid use disorder, and during the throes of their addiction missed a lot of appointments, and so now can't go there. I think 5 or 6 or 7 years ago, I may have done something like that. I don't think I ever did, but I think I would have thought about it. I think we thought more about discharging people from our clinic if they were not following the rules, if you will, or if they continued to have problems. But our I think our approach has changed horribly, and I don't know that there's
horribly. I would say for the better. No.
Yes.
I think, and we've talked about this a lot. I think it's a lot of what is obviously this harm reduction thing. Like, what are we doing for these patients? And is kicking them out of a clinic really going to help them, especially moving forward in their recovery? You don't kick out a relapsed breast cancer patient, for instance, like, oh, sorry, you got breast cancer, or, oh, I'm sorry, your A1C went up too high, peace out of my clinic. No, you continue to have these conversations and you continue to figure out the motivators, and that'll come up again in the motivational interviewing talk.
And I think probably in the history of our program, we discharged one patient.
Two.
One or two.
I did one, you did one.
Yeah, and usually the only thing that really gets us is if somebody's selling our pills, and they clearly don't have a use disorder. They're just getting the pills or the strips and selling them. And that's probably about it.
Can I make a comment though about that, just to make sure it's a little bit more clear? We all know that diversion happens. And so we know that patients may give away their films. They may occasionally sell one. Even if they are, in the program and taking the meds. The one patient that was mine that we did take out of the program, if you will, the police were calling us. They had her on video. They had her taking her prescription and selling the whole thing. Like, we are not the cops, but the cops were saying, dude, she's not taking your med. Here you go.
Yeah. The only one that I've had a patient, I had somebody ask me about another clinic was they had discharged somebody for violence. That's another one I think because there was threatening things to the staff. And I think that's also one of those things that would be case by case.
And I think those kind of situations, it's like maybe treatment inpatient.
Yep.
So Kurt and Heather, have you on one of the echoes, I know that we've been on talking about this before, the counter argument has been brought up about the lost revenue that occurs when people are no-shows in clinic. And so do you get pushback about that or do you not?
And I think that for the most part, we don't worry about that. Might people above our pay grade worry about that? Potentially. But I just disagree with, I think that it's such a common thing for people to miss appointments. And a lot of times early on, there's so much chaos in their life that I think we just have to take that in stride.
And I think some of that is, understanding the brain part of it, again, the whole thing I like to talk about, be like my kids that are home for the summer, a couple of them, it's like, okay, you have to leave by this time to get to basketball practice. So before I leave, Alexa, set a timer for 11:45 and call it, you need to leave for basketball. So, it's to have that, or tell my kid to set his cell phone alarm, like to expect that remembering. A couple of ways around that is, like our nurse comes in, and this morning she said, okay, are any of your patients who want me to call to remind them? Did I tell her call every one of them? No, because I know that some of them there's really no need, but yes, let's call these couple. And, as far as, higher ups and lost revenue, I think if you're me, you just say, really, I'm here for patients. And what's the mission of our healthcare system? And we're here for patients. We used to double book them, maybe like with a well child, so you have a little bit more time, but
creative ways. So,
all right. Case number 2.
So a patient starts on medication for opioid use disorder, has a job, has a very supportive family, but IV drug use?
Maybe has a history. That's what that means. History of IV drug use.
But does every patient need to go to treatment, Dr. Valley?
I love this question. And this is kind of how we centered our program way at the beginning, is we had one of our first patients, and we tried to, even before we got waiver, tried to get them into treatment and to get Suboxone before we could do it. And they're like, well, we can see them in 3 weeks, or they need to have an evaluation for treatment, like inpatient first. And No, we quickly realized that's not the goal. And I think it's, like this patient example is, well, is there a level of, you use IV, therefore you have to go to treatment, or you use multiple drugs, you have to go to treatment, or you have XYZ, you have to. Treatment, what constitutes treatment? If you look at the SAMHSA definition and the ASAM definition, it's any type of program where you're supporting the patient through their recovery journey, which sometimes is adequate in a clinic with a clinic care team or a provider who does some of that support.
Yeah. And I think that it's interesting that in the addiction clinic we're in now, I think it's always been connected to treatment. So it's always been connected to outpatient treatment. And so the natural progression is you see the patient and you set them up for treatment. And I think I don't always, although I think that has always been the way it has been done. And I think often it's if a patient's been through treatment many times and they come to me and they've lapsed and we restart their Suboxone, I'll ask them, do you think you need to do treatment again, or are you okay? And it's like, listen, I could probably teach it. I've been through it so many times. And so a lot of times I might have them do a little bit of outpatient, but if they really feel like, they're doing meetings and they're doing other stuff that's supporting them, I don't push it. I don't
Send a lot. Or if they've been, like you said, to treatment a lot. I had one patient, I argued with the assessor and said, no, I will not send this patient back to inpatient. He will do amazingly. He needs to do outpatient intensive. He knows how to survive in a locked unit or, in a contained environment. He needs to know how to function in society. And so I think it's definitely case by case, patient by patient, taking their consideration and what they want, and what will help them.
Yeah. And I've had a couple in the last couple of days that
if they're homeless,
they need treatment, right? And I've already arranged those, but it's case by case. And I think, remember that there are studies that show that patients in a buprenorphine program that is actually a very supportive program often do just as well as patients who go to inpatient or outpatient treatment. And so to me, it's like it's case by case.
Well, and then the kind of flip side of that is patients who are forced to go to treatment actually do just as well as those who voluntarily go.
Yeah.
And so I think the other benefit, if you will, to not sending every patient to treatment or having them do that right away is that when you do have that patient who has an ACE score of 10 and has like acute trauma response when you take away the coping, or who is homeless, or who, just about died and they're getting released from the hospital and they need to go right now to treatment, now there's access for them.
Yeah. I don't have much else to add unless somebody else in the audience wants to throw something in there. That'd be great about their opinion.
I think it really helps patients when you guys are upfront with them that you're not going to make them go to treatment right away, and getting stable is the number one priority. I think that relieves a lot of anxiety for them because, a lot of them have kids and jobs and they're worried about how all of that's going to go. So I think it really helps build that relationship and that rapport right off the bat.
And I think probably, as Erin's been our nurse in our clinic even for a really long time, is having that care team, that nurse for the patient, especially early on when they may need more help or more assistance. And then they need less and less over time.
All right.
Oh, did I miss one?
I don't think so. I don't think this one had one.
All right.
So should we do home inductions or in-clinic inductions? This is a question that is asked repeatedly. I think that I do both, but I probably do more inductions in the clinic than I do at home. But I think that when you have a patient who has been around the block and is very comfortable with Suboxone, has been started on it before and is not in active withdrawal in your clinic, then I often will give them instructions, as I did today. And yesterday, I had patients who came in who were not in withdrawal. And they've been down this road. So I wrote out instructions and had them call. So they will call this evening and let me know how it's going. So
I think to touch on this, how to spend also, I guess even early on in our program and even still, if I can do a home induction, I want to do, or induction, I want to do an in-clinic induction. I think Fentanyl, they don't get as amazingly amazing at first. And so I think sometimes having that conversation after that induction is at least started, saying, okay, you're not going to be perfect, but how are you doing right now after this baby dose? Versus, like when it was just heroin in the good old days, it was, man, you look great now. And now I'm their mama duck. And so there was something about that too, that trust building, that relationship. Yeah. Fentanyl has changed it all, because I think in the good old days of heroin, you could say, hey, you've started on Suboxone 1,000 times, or you took it on the street the first few times, you know how to do this. A lot of patients now think they can't take Suboxone with fentanyl. And so I think they're even more afraid.
Yeah. And I think one of the problems I've had is that I would say at least 50% of patients sent home with instructions on how to do an induction to avoid precipitated withdrawal take more than they should have. And I've had multiple patients who thought more was better, even though I had said don't do that, and have caused pretty significant symptoms. And so, again, the one thing I do if I'm doing a home induction, especially clearly everything's fentanyl now, is I am just reinforcing that you just got to stick to the plan. And if you think you need to deviate from the plan, you need to call me.
Right.
And so they'll have my phone number to call me.
And I think some of that is they're used to, if I don't feel good, I'm just going to use more of my substance. And
with heroin, that worked.
And with heroin, it worked. And then if you're just meeting that person, why should they trust you? I mean, the reality is why would I just not use more? Because that's what I know. And I don't know you from anybody. So
yeah.
Where's all of our questions?
I don't think they'll have. This one is an interesting question that we get. Do we need a urine drug screen every visit? So I think that this one is one of those ones that, in a way, often I feel like when I'm getting a urine drug screen on somebody, like yesterday, I had 2 people that have been in recovery for over 3 years. And I'm not quite sure why I'm getting a urine anymore. And in fact, in Baxter, when we're in Baxter for a day, and a lot of my addiction patients travel up there to see me, we can't do urine drug screens and point of care. And so, to be honest, everybody that I'm seeing there is so stable. A lot of times I'm not getting them because I just don't see the need in somebody that's been 3 or 4 years out as often. I'll do them occasionally, but we're sending them out, and so I'm not getting the results for a day and a half anyway. So
I think the point in what you just said, like long-term stability is, they're more likely to tell you anyway. And that'll be a question coming up. What's the law? Technically, it's once a year. You need to have a urine drug screen at least once a year.
Well, by guidelines.
By guidelines, yes. With it, a lot of them, though, I mean, if they're on probation, if they're on the color wheel, if somebody else is getting a urine drug screen, like, I'm sorry, I've had a patient one time who had 3 different urine drug screens. She was asked to leave in one day between my clinic, child protection. It's like, no, get releases to have them sent to your clinic.
Yeah. And I think some of the thing we have to think about is cost, especially if a patient, I've had a couple patients with very poor insurance. And often these drug screens, if they're costing $100, I won't do them every time because it's just another cost to them. And finances are often an issue in this patient group. So especially if they're not making enough money, they're making too much to be on MA, their insurance may have a very high deductible. So,
right.
So I would say in the early patients, I'm checking them every time. In the patients that are out of ways, I'm a little bit more lax.
And then what about the punitive nature?
Yeah, and this is I just kind of started thinking about this the other day. I have a lady who's 67, and she had an opioid use disorder from pills she was taking from her mother. And she is actually the best dressed patient I see. She's always comes in completely decked out. And I think to myself, am I?
Does somebody else tell you she's also good, well dressed, or is this just your subjective opinion?
She is well dressed. The nurse are like, she's always well dressed and very fashionable. But I think one of the questions I ask myself is this kind of punitive? I mean, how does this patient look at it? And I actually asked her. And she said, she's gotten so used to it, it doesn't really bother her. But, I told her my concern that she maybe felt like I was the police. And She didn't really feel that, but I did. So I do think that in a way it is a little punitive when they've been in recovery that long.
I try to really, I don't like, I mean, you got to really get out of the mentality of, am I trying to catch this patient? Like, if you're really concerned about a patient, you need to have the conversations. You need to ask them. You need to tell them your concerns. You don't need a drug screen to say, hey, look, I caught you using, you liar. No, I really prefer to not know the results of the drug screens before I meet with the patient. I will tell them that, like, I will do everything I can to not know the results because I want to have the conversation, because you know what? If they're going to tell me, that's better. I need them. I want that trust and relationship with the patient, that they're more willing to just tell me rather than me always feeling like I'm catching them.
Yep.
All right. This is not the super challenging one.
So you have this patient on Bupe for about 6 months, history of heroin, meth, marijuana, smokes and vapes, every other week, has every other week, every 4-week visits.
Now they're on Suboxone now. This is the history.
Yep. Last 2 UDOSs were positive for Bupe and THC. And today we were a little surprised by amphetamine. So the patient actually informed me to use meth once last week because some friends came over. So what do we do?
So do you get a confirmatory urine drug screen? Because this is the first time you've seen amphetamines in their urine or meth or whatever.
Well, do you?
Do I? No, I don't.
Yeah.
Will you describe what a confirmatory urine drug test is, please?
Good question. Okay, so when you're in clinic and you have point of care, there's just the original, it's like a screening urine test. So it's kind of like the rapid strip, you know, and then you send it for the culture at the rapid, you know, to just double check. And so a confirmatory is sent out, takes several days. It's gas spectrometry or whatever it is that building would know, but it really breaks down. So if a person has meth, is that it tells you what is causing the positive. Is it indeed meth or is it a false positive?
Now, in most of the urine drug screens, if somebody's using methamphetamine, their methamphetamine will be positive and their amphetamine will be positive. And actually, the farther you get out, so if you get out 6 or 7 days, you may only have amphetamine being positive because the methamphetamine is all turned into amphetamine. Sometimes if I get one and it's only meth and it's negative for amphetamines, that's clearly a false positive. Although if the patient said I used it, it's probably correct. So I would never do a confirmatory on that. Only if it's an unusual thing where there's, you know, if they were both positive that far out and you said it had been a week, a week down the road, it wouldn't be both positive, more than likely. But
so I'm gonna go with the comment a second ago. I personally wouldn't in this situation under legit any circumstances, unless something else was positive. They had told me they hadn't used. Maybe. He flat out told me he used. This is again why I don't want to go in knowing this was positive before I had a chance for him to tell me. And he told me, hey, I used meth sometime in the last week. We talk about it. I had friends come over. Sweet. And then my nurse says, yeah, there's meth in the urine. Do you want me to send it? No, I don't want to send it. One, again, back to cost. Is there really, I mean, he admitted it. We talk about it.
Yeah. And so it's just like any test that we'd order for anything. If we already know what the diagnosis is and what we're going to do, why would we spend another $150? I guess that's probably the overriding thing.
Right.
So I don't get a lot of confirmatories anymore because patients have already told me it's pretty rare unless somebody's saying they're not using anything and it's lights up. So I don't.
Okay, I'll run through the patient case and you start because this one's a little bit. So this patient, we're going to call patient number 4. Is going to kind of bring us to the end of today, actually. Going to keep bringing up lots of things. So this is a new patient you've never met before. You go into the room, heart rate's 112, pupils are dilated, sweaty, clammy, tremorous. They don't look great. Urine drug screen, you do know before you go in, has literally nothing in it. So what's going on with this patient?
Yeah. And so much of this is about what's not on the drug screen. And it's not just fentanyl that's not on there. There can be many other things that aren't on there. And so it's always important to understand, first off, why would they be dilated, which of course can be withdrawal, but it also can be benzos, can do that. And it can be other types of withdrawal, for instance, with kratom, where you can see an opioid withdrawal for something that a patient won't tell you they're taking because they think it's an herb and they think it's an over-the-counter med. I actually had that last week. I had a guy who we started on Suboxone, and I happened to just notice that he had said he was taking kratom on one of our forms, and he never really told me about it because he didn't think it was important. And so a lot of times patients don't think that some of these things are important. So fentanyl is not going to show up unless you have special dips. Kratom is not going to show up. Teneptine is an antidepressant that was used in Europe for a long time, still actually legal in some of those countries, but is clearly a mu receptor drug, very much like an opioid.
So I think like this patient, this looks like opioid withdrawal. He's telling you he uses opioids. I mean, that's not on there, but like this is like, if I could get a cows that look like this every time, I'd be like really excited. But so the whole point in this was that it looks like opioid withdrawal, and we get this question, like,
yep.
They say they're using Percocet, and everything on the urine drug screen is negative, but yet they look like they're in withdrawal. Well, right now it's fentanyl. Back in the day, it was kratom,
yep.
And so it's kind of that, what do you do?
Yeah, there's a number of places that would be thinking about teneptine up north, where there tends to be a lot more teneptine use that you can buy over the internet. So, but again, don't ever, you always need to understand as well, it can be two things. And so that person could be on a benzo and withdrawing from methamphetamine, or be using methamphetamine.
Yeah, but I mean, it's really knowing kind of what it should look like. So you choose to do this induction with Suboxone. The cows is 16. So now what do you do? And we did kind of what other things we talked already about in clinic or home inductions, but you're deciding, yep, we need to do this Suboxone, totally is opioid withdrawal, but what's the number one thing you think of right now, Kurt?
I think about precipitated withdrawal because I've had two patients in a row that were using Percocet that were fentanyl who had given themselves precipitated withdrawal in the last month. And so these are always touchy. My patient today was taking 15 Percocet 30s that are fentanyl per day, 15. And I can tell you the person I saw yesterday was only taking 3, and she was pretty sick. And so your chance of precipitating withdrawal, in my mind, is much higher, especially when we see people taking doses that large. To think that you're going to be able to sneak by with a regular induction is sometimes scary. So scary.
And then, like you mentioned before, the polysubstances, like, does this person have a benzo on board that wouldn't necessarily have been on that urine test? Did they have Xanax? Did they have Klonopin? Maybe they also had other things. And so especially with the precipitated withdrawal, right now, I think we're both kind of going the route that everybody gets low dose.
Yep.
And knowing that they might not, they're not going to have that light bulb, I feel amazing moment like they did in the good old days with heroin. And so not being afraid of the other medications like the Zofrans and.
Yeah. And I think the adjunct medicines, I mean, for me, I sent this guy out an hour ago with very small doses of Suboxone, literally cutting the 2 milligrams into quarters. I gave him clonidine, Zofran to prepare him for it and explain very much what's going to happen. So I think that I'm using more adjunctive medicine now than I ever have. I think when I was doing just heroin patients or oxy patients, I almost never used it. I mean, I can't remember the last time I did. Now it's almost every time. So yeah, be aggressive, because what you really don't want to
be aggressive with the adjunctive.
Yeah, with the adjunctive. Yeah, you want them to come back, and you don't want them to be so sick that they just ditch and use and don't come back. Or
don't end up in the ER with dehydration and from precipitated. Okay, so it's a follow-up visit. It's about a month later. We've had other visits, but it's about a month later. Your person's doing fabulous, mentions this history of anxiety and depression, kind of feeling a little bit off, PHQ 987, nothing extreme, but he brings it up, or she. Has a history of taking bupropion and sertraline on and off forever. So, what do you do? When do you consider the mental health medications and treatment for this patient?
Yeah, and this is a month out, and a month out is probably the earliest that I would start thinking about it. I think that my first thought always early on, if it's at 2 or 3 weeks and they're still complaining about it, is still that often in that rough water after an induction, they may still be anxious, they may still be struggling, but I think that at a month, especially if they have anxiety and depression and they've had a strong family history, I would think about starting them on something at that point, but generally not early. Actually, same patient I just saw today, his mom says this guy his moods are just so crazy, and sometimes he's up and sometimes he's down. But what he didn't know was he also had a positive methamphetamine. He had no idea that the Perk 30s he was buying had meth in them also. And so he's the classic getting meth and
drug-induced bipolar appearance.
Correct. He had the drug-induced bipolar appearance. His mom said he's so fidgety all the time. Well, that's not a classic fentanyl patient. That's somebody who's probably taking meth. And he said, I'm not taking meth. And I said, well, your urine says you're taking meth. And he was pretty shocked.
And then the other one, and we talked about this patient a couple of weeks ago, actually, is, the schizophrenia, especially when we're talking meth, with meth-induced psychosis. And are they schizophrenic? What if they did get started on, an antipsychotic, which is why if you can get to that month, at least, you really should never diagnose a mental health diagnosis while using a substance or within a month of stopping the substance.
Yeah, you may have to treat the symptoms, but don't diagnose, too early.
All right. So
4 months later.
4 months later. So did elect to go back to the meds he had previously been on, or she had been on, bupropion, sertraline. They had worked in the past. You got them to dose appropriately. I'm just saying now we're 4 months later, we're on them. Still brings up some anxiety and depression concerns, but we're still working on getting our meds up. Things are overall better. Get that urine drug screen now, and all of a sudden I didn't put Suboxone on here. Buprenorphine's positive too, sorry. And you also have a positive amphetamines, and you also have a positive benzo.
Yeah.
So now what?
Well, there's a couple of things to think about here. First is that now, if you had a patient that said, I'm buying benzos on the street, would you expect to see benzos in the urine?
Well,
no, you'd probably see fentanyl.
Well, no, okay. That's not the point.
Okay, but if the benzo's positive, what are these common false positives? And, meth and amphetamines are frequently the most commonly falsely positive tests. And so I think we always have to think about those, especially with SSRIs, right?
Right. And so the bupropion, very, very common to cause a false positive. Meth, any of the, like 5-ANCs or Adderalls, those will cause a false positive. Zoloft in particular, sertraline in particular, is notorious for causing a false positive benzo test. And these aren't universal, not in everybody. These aren't always going to be the false positives. So to kind of go back, I didn't put that in here. So kind of go back to that previous question on, do you get a confirmatory test on this patient? The first time I see this, I do. I know that these are probably false positives due to these medications. I'm always a little bit more careful on my medication choices. I wouldn't have probably restarted these 2 meds unless I have a very well documented history of these meds worked really well when this patient was not on substances on purpose. Like, I don't want to have to always question in my mind somewhere, is this a false positive or is this not? I don't want to have to order that expensive confirmatory. And so if you would have started this, even though I know these could be false positives, I will order them at least one time, a random confirmatory every once in a while, just to make sure.
Yeah, and one of the things I always think about too is some of these patients will end up getting put on amphetamines, like Adderall, after they're stable for 6 months or more. There is a contaminant in some of the stimulants of meth. And so you occasionally will get a positive amphetamine and a positive meth. And in fact, it's just the Adderall or a stimulant that they're getting that has like a very, very small amount of contaminant in it. So that's something always to think about. Get the confirmatory because that can clear that up for you. It would be super, super low. So.
All right. Okay, we're almost done actually. So we kind of went through this quicker than I thought we would. Okay, so this is still that same patient. We're now a few months more out. So we're at the 6 month or so mark. This patient's doing great. Anxiety, depression's better. But this patient is like, I am still exhausted. I'm not sleeping. And at first you were like, is that a depression? Is it early recovery? What is it? But now we're a ways out and this person's been doing well. Now what?
Well, these are patients that, again, we have to remember this is like a chronic pain patient on long-term opioids. If we have a patient on long-term opioids, it doesn't matter if it's licit or illicit, we still have to treat them as a person who's on opioids for long-term. And so all the normal rules apply and things that we would want to check.
So my go-to, and this was a learning thing for me. And this is where, this was a question I had, like, what the heck? I have this, my very first patient this came up on is this skinny, young, 20-something-year-old dude who's active and doesn't snore, doesn't have any of those like sleep apnea things. And it was like, why is he so tired? Testosterone will get brought up, took care of that. We treated that, blah, blah, blah. But it was like, dang, we need to get a sleep study. I don't know what else is going on. And sure enough, central sleep apnea. And this is something I don't think I was ever even taught as a student is, central sleep apnea, opioids impact the sleep center of the brain. And so whether you're a young, healthy person or not, central sleep apnea is a thing. I probably have a handful of 20-something, 30-somethings on who have CPAP machines due to the central sleep apnea secondary to the opioids.
Yeah.
What the research shows, which isn't a whole bunch, is that it typically gets better over time, especially in a younger person, even with buprenorphine, which is still technically an opioid, but it does still get better, but not necessarily understood. Yeah,
and it's interesting because I would bet right now I have 3 pending sleep studies in my patient group that I'm waiting to see. So it's something I actually order with some frequency if they're complaining about fatigue.
Can I comment one more thing on the sleep apnea? Very interestingly now, I noticed like when you order a sleep study in Epic at least, there actually is a question in there because everybody's trying to make everybody do home studies. But there's a question in there, are they high risk? And one of the high risk criteria is long-term opioid therapy.
Yeah, that is new. Now, testosterone we've talked about in the past, but the reality is just like the patients on chronic pain meds whose testosterones go down, people using chronic heroin, fentanyl, all of these things can as well get the testosterone. And I've had some patients that have literally had testosterone levels under 100 that from 6 to 8 to 10 years of opioids, illicit opioids. So I think that's something to always think about. Remember that replacing that improves all-cause mortality. So to me, it's a really important thing. Now, even if you're putting them on buprenorphine, there's still probably 20 to 30% of people on buprenorphine will continue to have a low testosterone. So for the most part, once I start them on testosterone, I don't stop it. But I recently had a patient who was on methadone and then transferred to be switched to Suboxone, and his testosterone was really, really low from years of methadone.
And, I think the other things in some of this you recognize right away, the screening lab work you do when you first see a patient, are you looking out for the hepatitis C's? We check all STIs, not just the hepatitises, because there's higher risk. And so making sure you're addressing all of those things in a patient, other substance use disorders, nutrition, they might not look malnourished at some point, but maybe they are. It's just being aware that this is whole person care.
Yeah. And I think the infectious disease part of it's important as well. Again, even if you got the initial blood work, you need to rescreen it 6 months out and make sure that Hep C is still negative. They may be very fatigued and having troubles because of something like that, or possibly HIV. And I think I have 2 patients with HIV, so it's not like it's never around. But I think that's probably an important one to look at. And
then ACE scores, social situations, we do get these right away. It's just important to know, like, what happened to these patients, like I had a patient this morning and we talked about his childhood and what happened to him. How did I end up using meth for half my life? And we really kind of talked about it and talked about new coping mechanisms. He was really hard on himself. Like, that was a coward's way out, he actually said. And I was like, no, you were like 14. That's what you've learned. Your mom used meth. Like, what else? That was like the right answer for you in a way. And then understanding their social situations. Do they have child protection involved? Are they on probation? What else is going on in their lives? Like significant others? Are they in a stable place? What's their kids? It's not just focusing on the meds and opioid use disorder.
Yep. And then of course, mental health, which we've kind of touched on. So that's pretty much it. That was kind of our fireside chat for the week. A little bit different kind of a thing, but just kind of touching on some of those common questions and things that we're faced with when we're seeing group patients. So happy to entertain any questions if anybody.
Yeah, other questions we
unmute or other questions you might have.
Address or thoughts, like what have y'all seen? Other anecdotes.
I think we're done early, Heather.
I think we're just so clear.
Yep.
As mom. Just kidding.
All right. Well,
how often? Good question, Laura. For depression monitoring, how often do you do a PHQ-9? I have not historically gotten those on day one because we have all the. I want to know their substance use history. I want to know like the intake stuff. I want to know their ACE scores more. A lot of that will come out of that. And so it's more that conversation over time. If you do start them on something, that just triggers it, at least in our clinic now, that if they're on something, they get the PHQ-9 every visit or at least every month, or, my chart reminds them to do it online.
Yeah, I never do it right away because when somebody's in withdrawal, you know what their GAD7 is going to be or whatever. I mean, it's going to be, they're anxious. I mean, you're going to get all kinds of super high scores, but then you got to say that you didn't do anything. But at a month, I'm certainly doing it.
Right. Yeah. Especially, they might not even know how to answer those questions at first.
Yeah.
They've coached their way through it. They don't. Yeah. So if it's a person who has that history, I'm much more for the conversation rather than screening tools.
Yeah. All right. Any other questions or thoughts before we say goodbye? All right.
This was super helpful. Thank you.
You bet.
You're welcome.
All right, everybody, have a good week. If you're there tomorrow, sex trafficking on our usual Wednesday echo should be a good time. So thanks again for coming.
Did you guys see, Kurt and Heather, did you see the resource I put in chat at the very beginning for you on some YouTubes that one of our ED SME subject matter expert did on changes of stage and scripting for talking to patients about that?
Cool.
Yeah, they're just really brief. He did a series on the theoretical stages of change, and they're just very brief YouTubes that say, this is stigmatizing language. This is why you might say it this way instead. So it might be helpful for that presentation, whatever.
Okay, sure. Perfect. All right, thanks.